Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Influence of Race, Socioeconomic Status, Insurance, and Hospital Type on Receipt of Guideline Concordant Adjuvant Systemic Therapy for Local Regional Breast Cancers by Xiao-Chen Wu et al. My name is Sharon Giordano, and I am an Associate Professor of Medicine at the University of Texas MD Anderson Cancer Center in Houston, Texas. My oncologic specialty is medical oncology. I'm recording a podcast titled Disparities in Systemic Therapy for Breast Cancer. In this article, Dr. Wu and co-authors have assessed the use of adjuvant systemic therapy in a population-based cohort of women with breast cancer. They used data that was collected by the Centers for Disease Control and Prevention's National Program of Cancer Registry's Patterns of Care Study for Female Breast and Prostate Cancers. These data were from 7 state cancer registries, supplemented with medical record abstraction. Their cohort included approximately 6,700 patients who were all diagnosed with breast cancer in 2004. 3 main endpoints were evaluated. First, they described the use of adjuvant chemotherapy in clinical situations where NCCN, or National Comprehensive Cancer Network, recommended for or against such use. Second, the authors studied whether patients who were treated with adjuvant chemotherapy received recommended chemotherapy regimens. The third aim was to determine the use of hormonal therapy when it was clinically indicated. The first finding of the study was somewhat surprising and discouraging. 35% of women who were eligible for adjuvant chemotherapy did not receive guideline concordant therapy. The vast majority of non-concordant care was under treatment, where patients did not receive chemotherapy despite being appropriate for such treatment. Only 1% of patients were overtreated. Among patients who did receive chemotherapy, most received recommended chemotherapy regimens. Only 12% of patients were treated with chemotherapy regimens that were not considered standard of care, as defined by the year-appropriate NCCN guidelines. The final endpoint was the use of hormonal therapy, and the authors found that 20% of patients did not receive hormonal therapy as recommended by guidelines. As was the case for chemotherapy, almost all of the non-concordant care was under treatment. 19% of patients did not receive hormonal therapy, although it was indicated, and only 1% of patients received hormonal therapy when it was not recommended. The authors then performed multivariable analyses to determine which patients were at risk for substandard treatment after adjusting for age, clinical factors, and comorbidities. One consistent finding across all 3 endpoints was that women living in high-poverty areas were less likely to receive appropriate systemic therapy. Of note, the authors did not have information on the financial status of each individual patient, but instead used poverty rates at the census tract level based on the patient's residence. The authors also reported that women who were treated at non-Commission on Cancer hospitals were less likely to receive chemotherapy or hormonal therapy as specified by guidelines. The authors hypothesized that the presence of multidisciplinary tumor boards and higher referrals to medical oncology at Commission on Cancer hospitals could possibly explain this finding. Insurance status was also associated with non-guideline therapy. Women who were on Medicaid were less likely to receive chemotherapy per guidelines, and women who were uninsured were less likely to receive standard chemotherapy regimens. One important and reassuring negative finding of this study was that there was no difference in the rates of guideline-appropriate care by race after adjusting for age and other clinical variables. This finding is in contrast to some other studies, which have shown that Black women are less likely to receive appropriate therapy. The differences between studies could in part be accounted for by the variability and adjustment for clinical and sociodemographic variables. The study had some limitations. Although the authors captured a very comprehensive snapshot of the use of adjuvant systemic therapy for breast cancer, the data were from a single year, 2004. Presumably, patterns of care have shifted between 2004 and the present, but many of the disparities that these authors identified likely persist. The study was also not designed to identify the underlying reasons for non-adherence to guidelines. However, overall, the study is a very comprehensive population-based assessment of patterns of systemic therapy for breast cancer. Although state cancer registries in the United States and the Surveillance, Epidemiology, and End Results Program, or SEER, collect detailed data on cancer incidence and survival, they typically do not have funding to abstract data on systemic therapy. Since most chemotherapy and hormonal therapy are given through many outpatient practices, the information on use of systemic therapy is very labor-intensive to collect. The National Cancer Institute performs periodic patterns of care studies to evaluate systemic therapy, but otherwise, population-based studies of systemic therapy are lacking. Among older patients, the SEER Medicare database has been used to study systemic therapies through linkages of cancer registry with medical claims, but Medicare data is generally limited to those patients who are 65 years or older. Other claims-based data sources lack information on cancer staging, so the appropriateness of therapy cannot be determined. Therefore, the information that the authors have collected in this study fill a gap in the current understanding of breast cancer treatment. Do these results apply to our clinical practices? I think that they do. These data are a sobering reminder that many patients are not receiving standard of care treatment, although the benefits of therapy are large. For instance, using estimates from the online tool Adjuvant Online, a 60-year-old woman with a 2.5 centimeter invasive breast cancer with one positive lymph node, estrogen receptor positive, grade 2, will have a 9% absolute improvement in mortality if she received an aromatase inhibitor, and 17.5% absolute improvement in mortality if she receives chemotherapy too. The findings of this study suggest that undertreatment may be a major contributor to disparities in outcomes among poor and underinsured women. Patterns of care studies, such as this article by Wu and co-authors, can identify gaps in quality care, but the crucial next step will be the creation of interventions to improve care for all groups of patients with breast cancer, with the goal of eliminating disparities in outcomes. This concludes the JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.